Rehabilitation, Dr. R.K. Sharma from Uttarakhand. He is a physician. Dr. Vijay Tyagi, he is an anesthetist from Uttarakhand and an intensivist. And Dr. Himanshu Kochar, he is an orthopedic surgeon from Uttarakhand and secretary of Uttarakhand Orthopaedic Association also. We welcome all the speakers. We have got our panelists, Dr. Anurag Verma from Kashipur. He is a medical legal consultant. Welcome, Dr. Anurag. Dr. A.S. Jaggi, he is member IMLEA and a general surgeon from Meerut, Uttar Pradesh. And Dr. Harish Bhatia. Dr. Rishi Bhatia, he is also general surgeon, past president of IMLEA. Welcome, Dr. Bhatia. We will be having our first speaker, Dr. R.K. Sharma. He is a alumni from MLB Medical College, Jhansi. He has done his graduation and post-graduation from Jhansi. Then he was in PMS, and now he is in practice as a consultant physician in Kashipur, Uttarakhand. He is having a great interest in nephrology also and in diabetes. Today's topic is management of diabetic patients in COVID times. I would request Dr. R.K. Sharma to share his screen and give his talk. Dr. R.K. Sharma, please.
Can you see it, sir?
You please share your screen.
You are not seeing the screen?
No, not yet.
Okay. Oh, Yash, स्क्रीन शेयर क्यों नहीं हो रहा?
You are just sharing the screen. Now share it again.
आपको स्क्रीन शेयर करना है. आप ये दूसरा पूरा स्क्रीन सेलेक्ट शेयर करना है. ठीक.
Yes, it is coming now. But
is it
yes,
fine?
Yes, it is good.
Thank you, sir.
You can start now.
Thank you, sir, for kind words. And I am thankful to IMLEA for inviting me as a speaker today. I'll be speaking a few words about the managing diabetes in the times of COVID-19. It's a very recent topic. I think everybody should be interested in it. So the overview of the talk is COVID-19 and diabetes, how they are related. General and specific precaution in the people with diabetes. And the measures in the people with diabetes who has developed COVID-19 and use of insulin in the time of COVID-19. Looking in the background, in December 19, there was an outbreak of unknown disease in China, Wuhan city of China, and the causative agent later identified as novel coronavirus. It was a new virus, so it was called a novel coronavirus. Virus named as severe acute respiratory syndrome coronavirus, SARS-CoV-2. And WHO coined the term COVID-19 to this virus. In the background, COVID-19 primarily spread through large respiratory droplets. Other routes of transmission cannot be ruled out, that is, fecal-oral route. Varied disease severity. The disease may be self-limiting, just a flu-like or common cold-like disease, to a fulminant pneumonia and respiratory failure and death. Yes? Respiratory failure and death. There are regional variation in the mortality rates. The mortality rate in Europe is different than that of India and Arabian countries. How does COVID-19 spread? The exact dynamics yet to be determined. Person-to-person transmission takes place by air, by coughing, sneezing, touching a surface with virus on it, then touching mouth and nose or eyes. Close personal contact such as touching or shaking hands. Respiratory droplets or close contacts. The mean incubation period being about 5 days. That ranges from 1 to 14 days. In 95% of the cases, the symptom within 12 to 12.5 days of contact. And one person is likely to give an infection to 2.6 persons. So what are the symptoms of the disease? The spectrum of clinical presentation may be asymptomatic infection to severe respiratory failure. The main symptoms being fever, fatigue, sore throat, dry cough, myalgia, and dyspnea. The uncommon symptoms may be sputum production, headache, hemoptysis, and diarrhea as well. In Delhi, there was a lot of cases report. They presented with diarrhea only. Although pneumonia is present in most, few cases complain of pleuritic chest pain. How does COVID-19 affect those with diabetes? A report of about 72,000 cases of COVID-19 increased mortality in the people with diabetes. That is 2.3% total mortality, but in diabetes it was 7.3%. That is, it's a threefold higher mortality rate in diabetes. And coexisting diseases of heart, kidney, advanced age, and feebleness is likely to have further increase in the severity. People with diabetes do face a higher chance of experiencing serious complications from COVID-19. So let us examine the risk factor characteristics of important lesson learned from the COVID-19 outbreak in China. Summary of the case report of about 72,000 cases from the Chinese Center of Disease Control and Prevention. Case fatality rate overall was 2.3%. No deaths occurred in patient below 19 years of age. And about 14.8% patient died who were 80 years or above. And 8% patient died between 70 years to 79 years of age. So what are the general precautions to be taken? The hand hygiene, the respiratory hygiene, the social distancing, and avoid non-essential travel. This way, you can break the chain to limit the spread. What are the specific precautions for the people with diabetes? The number one is good glycemic control, reduces the risk and severity of infection. Frequent monitoring of self-monitoring of blood glucose, stabilizing cardiac and renal status. Proper nutrition, correct deficiencies of vitamins and minerals. Regular exercise improves immunity and avoid crowded places. Self-quarantine, especially in high-risk patients like elderly. Influenza and pneumonia vaccination may lessen the chance of secondary bacterial pneumonia. What are the measures in the patient of diabetes with COVID-19? In case a person of diabetes develops symptoms of appropriate health authorities needs to be notified, number one. Affected person needs to be isolated for 14 days till symptoms resolve. Majority have a mild disease and can be managed at home. Current sick day guidelines for treatment of infection in patients with diabetes could extend to those who are diagnosed with COVID-19. What are the measures in the patient of diabetes with COVID-19? Number one is maintain hydration. symptomatic treatment with paracetamol and supportive care like steam inhalation, and possibly avoid ibuprofen. Anti-hyperglycemic agents then can cause volume depletion, should be avoided. Insulin is the preferred agent for control of hyperglycemia in hospitalized patients. Avoid hypoglycemia, especially in if chloroquine or hydroxychloroquine based regimen. And the precaution with anti-diabetic agents, analyze risk and benefit individually. Like metformin is one drug that can cause lactic acidosis. SGLT2 inhibitors are the drugs that cause volume contraction and fat metabolism and ketosis. GPL, GLP inhibitors can cause vomiting, and pioglitazine is the drug which can cause volume overload. So one should avoid these drugs. How to control hyperglycemia in sick patients where dose of other anti-diabetic medication is reduced or withdrawn. All the patients where anti-hyperglycemic medication are being considered for temporary dose reduction because the patient is not well and he is not eating anything, discontinuation occasionally. The basal insulin with or without bolus to be used to maintain good glycemic control. And insulin remains the drug of choice in sick patients. In hospital management of hyperglycemia, that this slide is very important. The level of care is ICU, then the glycemic target should be 140 to 180. And the insulin used should be regular insulin. And the route of administration should be intravenous. The dose calculation, adjust insulin infusion rate based on the blood glucose values. And if the patient has been shifted to ward or non-ICU, then the fasting should be between 80 to 120. Pre-meal, it should be less than 140, and post-meal, it should be less than 180. The insulin used should be basal insulin and basal plus a bolus. And the route of administration should be subcutaneous. The dose calculation should be the 50% basal and 50% bolus of soluble insulin. Individualized correlated bolus. Avoid sliding scale of insulin. Apply the 6-day rules. 6 stands for S for sugar, I for insulin, C for carbohydrate, and K for ketones. There has been a controversy and a hypothesis. Patient treated with ACE inhibitors and ARB will have increased number of ACE2 receptors in the lung. So there may be increased risk of severe disease outcome due to COVID-19 in patient with ACE and ARBs. This is an hypothesis. This speculation about the safety of ACE inhibitor or ARB treatment in relation to COVID-19 does not have a sound scientific basis or any evidence of support. Physicians and patients should continue treatment if they are on usual antihypertensive therapy, because there is no clinical scientific evidence to suggest that treatment with ACE inhibitors or ARB should be discontinued because of the COVID-19 infection. Hospitalized patient with severe disease needs a frequent blood glucose monitoring. Oral agent, especially metformin or SGLT2 inhibitor, needs to be stopped. Insulin is the preferred agent of control of hyperglycemia in hospitalized sick patients. Unproven therapies and future directions. The use like lopinavir, ritonavir, interferon 1L, 1 beta, RNA polymerase inhibitors, remdesivir, and chloroquine, hydroxychloroquine has been reported. But there is no proved role of these drugs. 2019 and receptor binding site has a strong affinity with ACE2 inhibitors, There's a spike protein of the virus that attaches to ACE2 inhibitors of RNA, the cells. So zinc and nanoparticle were shown to have inhibitory effects on H1N1 viral load, though their effect in COVID-19 is unknown and untested. Vitamin C supplementation has some role in prevention of pneumonia, and its effect on COVID-19 needs evaluation. Effort to develop a vaccine is underway, which will be a major tool to contain this epidemic. So the conclusion and key consideration and take home message is the people with diabetes have an increased risk of developing infection, including COVID-19. The patient of diabetes have a risk of developing all the diseases, so they have a risk of developing COVID-19 as well. The people with diabetes have a greater chance of serious complication from COVID-19. The risk and severity of COVID-19 in people with diabetes can be reduced with general precautions, and that is good glycemic control and proper monitoring. When anti-diabetic medication are considered for temporary dose reduction or discontinuation, the basal insulin or basal plus bolus can be used for good glycemic control. And insulin is the preferred agent for control of hyperglycemia in hospitalized patients. Thank you, sir. This is all.
Thank you, Dr. R.K. Sharma. You have given good overview of the management of diabetes in COVID times. And I would request you to please unshare your screen. It is on the top. Our next speaker is Dr. Satish Agrawal. He is a pediatrician from Amravati. He is past president IAP Amravati branch 2012, executive body member of Maharashtra IAP in 2013-2016. He has been organizer secretary of Maharashtra Pedicon in 2005 and organizing chairman of the same in 2019. He is involved in social services by conducting TV shows on various health issues since last 5 years, writing in local Marathi newspapers since last 23 years. He has received Excellence Award for Social Awareness by CIAP in 2018. Dr. Satish Agrawal will be talking on immunization in COVID times. Welcome, Dr. Satish. Please share your screen and give your presentation.
Thank you, Dr. Sir, Dr. Anurag J. Verma, and all the galaxy of speakers. I thank Dr. Sharma sir for such a nice presentation. As told by Dr. Surgeries sir, the topic is immunization in COVID times. So aims and objectives will be importance of vaccination or immunization. During lockdown period COVID times, the vaccination practice got hampered. What were the reasons? If vaccination practices were hampered or stopped, what are our past experiences? What is the current status and guidelines regarding vaccination and immunization? And the most important, vaccination in corona infection. We all know vaccination is a life-saving measure. it saves around 20 to 30 lakhs children per year. If we take an example of measles, we started since 2000, it saved not less than 3.2 crores child deaths. But the other aspect of vaccination is still 2 crore children they miss out vaccination. If we talk about India, not less than 2 lakhs children under 5 years of age, they die per year, and the two most common diseases are pneumonia and diarrhea, which are vaccine preventable disease VPDs. This is supposed to be the safest and most cost-effective way to end vaccine preventable diseases, the disease which can be prevented by vaccination. And according to WHO, 20 life-threatening diseases may be covered by vaccination. It has been said it is the child's basic right to get protected from vaccine preventable diseases and a key component of primary health care. How? Vaccination boosts immunity and also provides herd immunity. Because diseases like pneumonia, measles, they may be prevented by vaccines, which make the child immunocompromised. If immunity is increased, child becomes boosts his immunity. Most of the parents they come to increase the mental power or academic performance of child. Vaccination does it. How? Because the child falls sick less time, there will be less medication, less hospitalization, increased school days, and better performance. Obviously, it's an economic measure because parents they have to spend less on treatment and child is better. One of the neglected aspects is if vaccination is done in a proper way, it decreases antimicrobial resistance. It is supposed to be next pandemic. Antimicrobial resistance, India is supposed to be the capital of antimicrobial resistance. Because the child is protected as diseases like measles, pneumonia, so less prescription of antibiotics, and suppose viral diseases are there, so antibiotics will be prescribed for a less time, and the development of antimicrobial resistance will be less. And this shows the importance of vaccination when we are waiting for corona vaccine. Otherwise, the disease has become a pandemic. Now, this is the prologue of COVID. WHO declared is a global health emergency in January 2020. It was declared as pandemic on March 11. India declared lockdown on March 22nd for 21 days this year. It was to last up to 14th of April, but again extended to May 3rd, 2020. Now, why this is important to discuss? Because India being a resource limited country, all primary focus was diverted for preparedness and containment of COVID-19 pandemic, and because our main immunization vaccination practices is covered in private as well as government agencies. So immunization got disrupted during lockdown. As we see, most of the healthcare workers they were diverted to contain this disease. But it is not the only reason. The main was caregiver of the parents. They were afraid to contract the disease. As Dr. Sharma sir said, the fear of spread not only by the droplet but touching the surfaces also. There were various messages. One of the messages was stay at home because lockdown was imposed. Another message was only emergency services are to be continued. Otherwise, routine services like the well baby clinic or neonatal services should be temporarily abandoned. So people were afraid and they were staying at home. WHO on March 26th, they said mass campaigning of vaccination should be temporarily stopped, but routine immunization should be continued. What happened? Because social distance was to be followed, the vaccination campaigns were postponed. Result, all those diseases which could have been prevented by this vaccine, there was a risk of getting these diseases after the lockdown was open. But there was a risk to healthcare providers also for two reasons. One, for its services, they were either diverted to contain the corona or they were burnt out, so much workload was there on them. And we all know the vaccinator or the healthcare workers, they are increased risk of infection. In one of the Delhi study, 1 out of 15 healthcare workers was infected because of corona. We all know nothing to be innovative over here because the doctor or the medical is more in contact with the number of people they come, and stringent standard of infection prevention such as wearing suitable PPE and frequent hand washing. It is easy to say but very difficult to follow. Resource limited countries, for example Kenya, the space which was provided for vaccination of primary healthcare, it was diverted to corona containment. PPE so less. So not all the healthcare workers, including the doctors, sisters, and other paramedical workers, they were provided PPE. So immunization practice, it got suffered, and especially in private sector, because PPE to provide to each and every staff near to impossible. Unavailability of vaccine because all the traffic and the transport media were stopped, and parents' inability to travel to clinic due to lockdown. And because of this lockdown, people were deprived of the employment. They had the economic hardships too. Needless to say, university also what is called as a WhatsApp university. There were so many messages, including some of the medicos. They were the reason for the various misconceptions, myths regarding corona, and because of this, immunization and vaccination practices suffered. Now, if such is the effect of corona, what are our past experiences? If immunization practices they are temporarily abandoned or stopped altogether. In Congo in 2014 and 15, there was an Ebola outbreak. Disease was supposed to be so contagious, so people were afraid of going to health clinics. Ebola could be contained, but the vaccine preventable diseases, they rose like anything. And when the figures came out, it was found that Ebola killed only 2,264, while other diseases which could have been prevented, vaccine prevented, they turned out to 6,500, like 3 times more than the Ebola. So just to contain Ebola, vaccine practices were hampered. Result was the vaccine preventable disease on a rise. In 2018, approximately 2.6 million children in East Asia and Pacific did not receive their measles vaccine or the third dose of DPT. Result was huge outbreak of measles in 2018 and 19. In lockdown, in UK, MMR vaccine dropped down to 20%. In USA, in March 2020, there was sharp decline in measles vaccine. What are the results? These children who could have been protected against respective disease, now they are vulnerable to get such diseases. So, at one hand, the children will be suffering, and other hand, there will be additional burden on the healthcare facility who are struggling to contain corona. Now, as soon as the lockdown, it will be open. So there will be free movement of people. So vulnerable group, especially children, they will be at increased risk of contracting the disease, especially measles. And if the routine vaccination are postponed, including the polio vaccination, the children are vulnerable to get polio. Mind well, barring 2 countries, Afghanistan and Pakistan, polio is supposed to have been eradicated control all over the world. But even if a single case of polio is there, it exists, polio can't be labeled as eradicated from the world as with smallpox. Now, all these names, WHO, UNICEF, Gavi, Boost, these are all the names of the international agencies concerned with vaccination. They did a survey in 128 countries about the vaccination practices during COVID times. They found that immunization practices, they were moderately or severely disrupted or were altogether suspended. What was the result? They predicted that now, let's say, 8 crore children, they are at risk of acquiring the diseases which could have been prevented by vaccination. And that's the reason, if lockdown are relaxed, these children are more likely to get the diseases. Apart from that, the vaccine practices which have continued since decades, and the child and neonatal mortality was dropped down drastically. If there is a gap in vaccination, all these figures, they will go again high, resulting in increased mortality or morbidity. So, friends, And what is the result of a child mortality? We consider child as to be seed. We don't know the potential of the child, which way it will take turn. With due respect to our physician friends and other colleagues, as compared to adults which have got a limited lifespan, the child has got a full lifespan. Hence, childhood mortality is more important and we want to prevent that mortality. So scientists at this institute, they weighed up if we want to prevent COVID death by stopping the current immunization practices. What is the result? They found that to prevent one corona death, there are likelihood of less least 34 and the most 1274 deaths resulting from the diseases like measles, polio, meningitis, pneumonia, diarrhea. And all these deaths, vaccines are available against these diseases. They are quite controlled by protected by these vaccines. So what should be the advice regarding vaccination? The safety measures for healthcare providers, caregivers, and children should be followed strictly. What are the measures? As Dr. Sharma sir said, safe distancing, hand washing, cough and sneeze hygiene. One should not cough and sneeze at hands. Neither at distance. They should use this elbow over there. Complete the vaccination schedule as early as possible. Whatever vaccinations were left, age-appropriate vaccination, one gets the opportunity, complete the schedule. Provide catch-up immunization for any children who miss their vaccine. Now, this catch-up immunization for our non-pediatric friends may be a new term. The vaccination which could have been given at appropriate age, but child could not receive for one or the other reason. When the opportunity arises, this vaccine should be administered in the future. Course of the vaccine should be done. This is what is called as the catch-up vaccination. Now, what is the advice given to the child or caregivers? They should maintain adequate physical distance in waiting area. Similar, while traveling from remote areas, they should follow the same physical distancing during travel. And to avoid getting exposed to sick children, they should take prior appointment. And there should be minimum gathering by reducing caregivers. People should minimize time spent outside the home. Because we have got the experience when the child is brought for vaccination, there are a lot of questions we need to answer called as the counseling. But this time, our advice is we can answer all the questions at other times or by other means like WhatsApp or telephone, but there should be minimum time spent in the hospital. Healthcare giver, the medico, the vaccinator, they are the most important person. As we see, there are more chances of them getting infected. So they should ensure infection prevention and control measure, what is called the IPC. They should protect themselves and the children by scheduling sick visit and well-type visits at different times of the day. Like if they have given appointments for the vaccination, it should be different. And the sick children or the routine OPD should be at different times. Should have exclusive vaccination stations and exclusive vaccination rooms. And if it is not possible in metro cities or in small chambers, the time should be different. And before giving the vaccination at vaccination time, it should be very well sanitized. Reducing crowding in waiting room. So as I said, there should be less caregivers accompanying the child, or if possible, the relatives can wait in the cars or other places. They should be asked for seat. Screen the accompanying individuals for fever and respiratory symptoms, presuming it could be a case of COVID. And if any caregiver having cough or cold or fever should be barred from entering the healthcare facility. Senior citizen, Dr. Sharma sir said, more than 60 years of age, they should be requested not to accompany the vaccine. Because it's our experience, Dada, Dadi, Nana, Nana, they usually accompany the child and having so much of queries and advices to we people also. All caretakers and children, except infants, should wear a mask. Except infants in the underlined word, because most of them will see a 3-month or 4-month-old child wearing the mask. No need for that. And as I said, we need to protect the healthcare worker from getting infected or from becoming a source of infection. If the healthcare worker gets infected, the staff, the healthcare facility will be shut down, getting a very setback to the society. Now, advice to the vaccinator or the medico: sanitize the area of vaccination. If possible, there should be a separate area of vaccination. If not, you cover that area, sanitize it properly. All the hospital floors, height of surface area, equipment, etc. should be regularly sanitized. There should be minimum handling of files. No need to handle the files. Old prescription, every time you give new prescription. Investigation report you can see from a distance. So there would be less of, sir said hand touching, so less of the surface touching. Digital payment, if possible, should be asked for. Consider telemedicine. I said that all this counseling may be done by telemedicine, and keep oneself updated because there are so many queries and questions from the relatives because there are so many sources of information. So one should be very accurate in giving the answers. Prioritize vaccine and routine immunization. For non-pediatric colleagues, just to sum up the thing, as soon as the baby is born, vaccinate the child over there only. Then the primary immunization, all these vaccines should be preferred rather than the vaccine at later age, the booster. Pneumococcal and influenza vaccine to vulnerable group, as I said, in older age group or the vulnerable age group should be given. Now the main topic, immunization in COVID period. The question is it safe to vaccinate children during the COVID-19 pandemic? We saw that the practices got hampered. Surely yes, because there is no documented risk of immunizing a well child during COVID-19 pandemic. It is an evolving disease, but there is an apprehension if the child is vaccinated, all his immunity will be diverted toward that antigen and child becomes susceptible to acquire COVID-19. There is no proof, no evidence for that. Why is vaccination particularly important during COVID-19 pandemic? We have seen all these things to summarize to prevent vaccine-preventable diseases like measles, diarrhea, pneumonia, etc. Some of the hospitals, they have a protocol, like before entering, they should have a COVID-19 test indicating that it is negative. Should we ask for the children to get it tested before giving vaccination? Answer is no. Is COVID-19 a contraindication for vaccination? If the child is suffering or is in the incubation period, answer is no. Mild symptoms like cough and fever, there may be symptoms of COVID, but not necessarily contraindication of vaccination. But the decision lies over the vaccinator or the doctor. If he feels, he based the risk-benefit assessment. If he feels the child may be benefited by vaccination, he may very well give. If he feels it may be postponed, taking into consideration the parents, it may be postponed someday. Is it dangerous to vaccinate a child during the incubation period of COVID-19? We don't know the status of the child. Child is brought for vaccination. We need vaccination, and later on found that the child was in incubation period. As I said, because by vaccination, his immune system was diverted to particular antigen. Did it make the child more susceptible? Answer is no. Should we vaccinate the child? Answer is yes. Now this is the last slide. What are the key home messages? Urgent action is required to maintain vaccination rate and limit preventable infection. Vaccination should be done at all costs. Maintain proper arrangements to gain the confidence of the family. Because we know a pediatric population is a mobile population, they go from clinic to clinic. Many of the new parents, they got access to all this net and other people where they get information how the vaccination site should be. So you should make proper arrangements so that you gain the confidence of the family. Now there is a question from the parents. It also we missed the vaccine which was due about 2 or 3 months back. Will it hamper the status, health status of the child? Theoretical answer is yes. But in such period, when it was not advisable or the facility was not there, so you should reassure the patient that vaccination at a later date is also manageable. But the future course should not get delayed. And utilize every healthcare visit for immunization provided there are no contraindications. So at all costs, vaccination should be completed. And then a big thank you to all the organizers for giving me the opportunity. Thank you.
Thank you, Dr. Satish, for covering all the aspects of immunization very clearly and giving the guidelines to all. Our next speaker is Dr. Sudhir Mishra ji. Dr. Sudhir Mishra is pediatrician from Jamshedpur. He is chief consultant and HOD pediatrics Tata Main Hospital and HOD pediatrics at Manipal Tata Medical College Jamshedpur. He is past secretary of IMLEA. His today's topic is medication errors in clinical practice. Over to Dr. Sudhir Mishra.
Thank you, sir, Dr. Siroi. And right at the outset, I would just like to ask, I hope I am audible.
You are.
Yes, you are audible.
Okay, thank you. I would like to express my gratitude towards the IMA Uttarakhand and also towards the IMLEA for giving me this opportunity to share my thoughts on medication errors in clinical practice. Now, this is often a neglected topic. Why it is neglected? Because it is often not realized that it occurs. We never feel that we are causing medication errors. However, once you are aware, as Tulsidas said, that Manas rog kachuk mein gaye hai cycle घुलन पाए जाने ते चीजें कछ पापी. So जानने से पता चलता है that it does happen, and therefore this sensitization exercise for towards the medication errors. What is the definition of medication error? A medication error is a preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of either healthcare provider or the patient or the consumers. So it's not that only when you are giving medications in the hospital, medication errors will occur. Also, when the patient is under their own care at home, you have just prescribed the medication. It can occur because of the certain reasons that we will call. Is it a reality? Is the medication error a reality? It is a reality. It is a reality because I'll show you some data on the medication error from different parts of the world. It can occur in all the hospitals and nursing homes. It can occur in our private clinics. It can occur during immunization. I have personally faced one such situation wherein a vaccine, two children came from the same family for the vaccination. Parents continued to talk. I loaded the vaccine and then administered the vaccine required for the younger child to the older child. So this can happen in our clinic and personal practice as well. Now, this is just to show that medication errors occur everywhere. It's not an Indian phenomenon, it's a worldwide phenomenon. NHS estimated that about 2,000 people die because of the NHS errors in the medication. So 2,000 people dying just because of the medication error is a huge number. I mean, today we are talking of corona deaths, which have touched huge numbers, but then medication errors, suppose they occur 2,000 only in NHS UK, then you can imagine what happens in the world. Probably maybe a lakh or so people may be dying because of the medication errors, because there is no assessment of worldwide data on this. Now, medication errors, what we see, like this 2,000 deaths that NHS talked of, it is an tip of the iceberg. Why I say this is the tip of the iceberg? Because this is the number of reported cases we get. Often, as you would experience in your own clinical practice, especially those who are in hospital, once the medication errors occur, it is almost impossible to find who administered the medication. The records will not be there. Sisters will not be coming out with the truth. Doctors will not come out with the truth. And therefore, a lot of medication errors, they are unnoticed. The actual errors are not noticed. Potential errors are there. And then errors identified but considered insignificant to report. So this can, all these phenomena, they occur in our clinical practice. So the reported errors are only the tip of the iceberg. Now, is there a proof? Yes. This, again, a BBC News, I will quote. the doctors are not reporting medication errors. And I will come to the topic why doctors are not reporting of the medication errors. But their data suggests that almost 80% of the medication error that occur, they are not reported by the doctor. And this I'm talking of UK, which is a far more open society than that of ours. The consequences of reporting are much less than in our setup. In our setup, administrators will simply like to issue a show cause notice or something, or fire you. And if it is a personal clinic, then you may have halla gulla and all sorts of that IMA keeps dealing for us, thankfully. So uh, the errors are not reported. Now, what are the most common errors? And this I'm talking of pediatrics, because in pediatrics, the dosing is the very important part. Every children has to have a customized dosing schedule based on his weight or body surface area, unlike adults where doses are more or less fixed. But dosing errors can occur even in adults. The route of administration may become inappropriate. So intramuscular injection may have been given subcutaneously or something. There can be transcription or documentation errors. There can be wrong date for the medication given, so that your calculation of date becomes, again in pediatrics, the wrong date for vaccination may be an issue. And then the frequency can be wrong. So the 5 rights that you're supposed to have for the medications, the right route, the right dose, the right time, and the right patient. Any one of them can go wrong, especially in hospitalized patients. Now, one of the examples, baby died after decimal error. What is a decimal error? So you wanted to give him 0.5 ml injection. You didn't put 0 before 0.5, which is the recommended way of writing 0.5 ml. Somebody didn't put a 0 before it. 0.5, sister did not notice that point because it is so small, and administered 5 ml instead of 0.5 ml. Now this can lead to death. I have a personal experience as house officer. I told the staff nurse to give quarter ml of diazepam to a small child, an infant, and she didn't understand quarter. I said 1/4 ml of diazepam, and she administered 4 ml. What was the consequence? The child went into immediate respiratory arrest. We had to sort of bag and mask, because at that time when I was a student, intubation and ventilation facilities were scarce. They were simply not there in my hospital. We had to continue bagging because I knew diazepam effect will wean off over a period of 3 to 6 hours. We actually backed that child for 6 hours, and then the child started having its own respiration. Fortunately, saved for us. But then it was a medication error that could have, killed the child. What are these errors? So, as I said, wrong dose administration, very common in pediatrics. Dose not administered is again something very common, just because the sister got too busy, or it was a handover time when the dose was due, or she simply thought she has already administered the dose, or the additional dose is given. So she forgot that she has already administered the dose, again went and gave the same dose. Wrong drug given. So there is something called LASA medication. LASA medication is simply what we call look-alike and sound-alike medication. Now, look-alike medication means the appearance of the ampules or the vials is similar. Now, once you have these medications, what is the way out is to put a sticker. And in our hospital, as recommended by NABH, we put a pink sticker on the look-alike medications, so that whenever a sister identifies a look-alike medication, she is supposed to double check the label on the medicine, so that she is not giving another medicine which appears, identical in the ampule shape, size, color, etc. Wrong infusion rates are again very common in pediatric practice, and they are also common in adult practice. We have all seen deaths of the children in older days when the infusion pumps were not there because of the excessive administration of IV fluids. very commonly used to happen in younger children, because the the rate adjustment that was there with the infusion sets did not work properly, or it was not administered, set properly. Then there can be dispensing and labeling error. I again cite a personal example that I faced. I prescribed a medicine called Allegra, and the parents came back after 2 days that there is no response. She said, "Are you giving medicine?" "Yes, sir, I am giving medicine. But the syrup that you prescribed was not available. So the pharmacist told me, the shopkeeper told me that there is no syrup for this medicine coming. So you take a tablet and give quarter tablet." And the medicine dispensed was Viagra instead of Allegra. So this dispensing errors can occur. There can be wrong IV concentration. Again, common mistakes occur in the infusion of drugs that are used given by continuous infusion, like adrenaline, noradrenaline, the vasopressors, or sometimes the sedatives like midazolam, which are infused in ventilated patients, the pain relievers that are infused in ventilated patients, fentanyl, etc. And this can occur in wrong concentrations. There can be overdosing or underdosing, and both are harmful. I have seen a situation where a wrong person was administered an injection, and this was as an intern. I still remember this case. The lady, I was posted in gynec side, obstetric side, and this lady went to bathroom, and her attendant was sleeping, and sister simply went and without asking anything injected to the attendant. And these are real cases. This I'm not sort of making up, and that is why I'm talking of my internship days, not of the current days. And the wrong route, it can be inadvertently wrong, so a subcutaneous injection given intramuscularly or vice versa, and there can be anything others. So these all can die. But there can be situations where medications error may be inappropriately implicated, like in this case where 36 children fell ill after DPT injections. We all know illness after DPT injections are very, very common, and this is not a medication error. This is a known side effect, and this can happen. Now, one of the important causes where our practicing friends who are involved in office practice, or even when we sit in OPD as hospital practitioners and write in our pen, the bad handwriting can lead to drug errors. And possibly that Allegra Viagra thing that I talked of was an example of my bad handwriting. And since then, I have started sticking to the MCI guidelines of writing all the medications in capital. Now, this is also an NABH recommendation for all the hospitals that the name of the medicine has to be written in capital. And the reason for that is avoiding the medication errors or administration of different drugs. The short forms are another thing that has to be avoided. I will again like to cite a personal example that I faced. So somebody said chloro is to be given 500 milligrams 6 hourly. And the sister wrote chloro, and in one of the doses, sister administered chloroquine instead of chloramphenicol or chloromycetin, as it used to be called. Again, an old time, my residency, days phenomena, not of the recent times. So the short forms have to be avoided in writing the prescriptions. You don't have to write PCM or something, because PCM and CPM can be easily, CPM is chlorpheniramine maleate and PCM is paracetamol. They can be easily, switched while sister is transcripting your advice, or the dispensers in the pharmaceutical. Many of them are not actually trained pharmacists, and that can lead to. So we need to follow this recommendation of writing in capitals. And believe me, it's easy. It's as easy as writing in cursive once you start doing it. You will have face problems for a week or so, and after that the habit will become, and you will not ever write in cursive writings. And this is the order. Doctors ordered to write in capital letters, and the Reason is to prevent the medication errors. Right, legibly, doctor told, and this is a court guidance, the Karnataka Medical Council case, and that was there. How do errors occur? Medication errors are never. Are they deliberate? Of course, they are not deliberate. No doctor or sister would want to commit an error deliberately. So nobody does it. It's the fault of the system, and these systems need to be looked at. Even when I say system, it does not mean that it's applicable only to the hospitals or nursing homes. We need to look at our own systems when we are practicing in office as well. Usually the result of combined effect of latent error in the system, which gets combined with the active failure because of the some or the other reasons. Why do individuals make mistakes? Because they are in psychological state of stress. There are interruptions, like phone call came and you forgot what was being talked previously and what is being talked now. There is lack of information. Sometimes more than one person keeps talking. When you are taking history or examining a patient, people continue to talk. You have to stop them. Please let me examine the patient and then we can talk again. There can be calculation errors. There can be brand errors. There are brand names. Once I had posted a WhatsApp mail. I didn't get that again. Those photographs, I would have loved to put it on this. Same name of the drug, and there were 4 different drugs registered in the same name. And if I can get that, I would be happy to include it in this brand. So you write the brand and somebody will get this and somebody will get a different drug. So that also happens in India. There can be a confirmation bias. People don't try to confirm the medicines that are being dictated by the doctors. There can be tiredness or the stress. The noise, as I said, noise can be because of the people continue to talking. There can be heat and the tiredness on the part of, or there can be simply high workload. Sometimes you will find that in our wards there are very few sisters for the number of patients that are there. So it is usually a combined effort. This typical cheesecake diagram shows that it's not one error that occurs. It's sequentially when 2 or 3 places the check is not there, then the medication errors occur, and therefore the systems have to be put in place to avoid this phenomenon. Unreasonable to expect that every time, 100% of time, you will be perfect. Of course not. It is not possible, and therefore systems have to be built to check the error. Once it is caused by one person, somebody else can pick it up. So systems need to be in place. They provide for providing opportunities to check. The good communication to the parents, you need to make them understand what the medicines you are prescribing, and sometimes ask them to revert back if you are not sure they have understood it, or if you are not sure whether they can read the medicine, you can ask them to revert back to show the medication so that you are sure that they have got it right. There has to be, especially in hospital, the post-error evaluation system, wherein you can identify the system deficiencies and then correct it. Of course, children are at greater risk because of the drug doses calculation that are based on weight. Sometimes the weighing machine may not be available, or weighing machine may not be recording appropriate weight. Calculation of surface area other than hospital is rarely done. Sometimes there can be weight changes, especially during infancy. So you write a dose for 4 kg when the child has become 6 kg already. And then there can be 10 folds error. So 10 folds error is like I cited, 0.5 ml becomes 5 ml. So that type of errors can be there. There are formulations like syrups, drops, and syrups of different concentrations. So somebody is manufacturing 250 milligrams, somebody is manufacturing 100 milligrams. And we used to see one phenomena very commonly. There was a time when a dilantin syrup was available, and this syrup had 125 milligram dilantin, phenytoin in it, whereas the tablet was of 100 milligram. People who did not know this will prescribe, like every syrup, 10 kg, 5 ml is adequate. So the huge overdose phenomena we have seen occurring with, fortunately, that syrup has been withdrawn from the market. Then there can be inadequate information to the prescriber, what I call MRCP phenomena. Everybody wants to do an MRCP. And this MRCP stands here for medical representative council practitioner. So this MRCP has to be avoided strictly. Once you start using a new drug, I'm not talking of using a new brand, I'm talking of using a new drug. You have to read about that drug. You have to know the proper doses. You have to know the side effect of the drug before you first time pen that drug. And again, I'm not talking of new brand, I'm talking of new drug. And that therefore has to be done. And you don't have to rely on the information given by medical representative. You have to do your independent study, or at least read the package inserts which do not fool. Package inserts of all the drugs are adequately given adequate information. Incorrect use of dose information resources has to be avoided, and you have to use the proper dose information, the reliable places or reliable books. Lack of suitable doses form and concentration, and need for complex calculations and dilution. So all these can cause medication errors. Neonates are at higher risk because they get fractional doses simply, and many times our doctors, the residents and the staff nurses may not understand the proper fractional doses. It has to be explained properly to them. Third baby die because of, and this is Indiana hospital, this is not an Indian hospital. So Indiana is in USA, and you can imagine the babies dying of the medication errors. Third baby died, it's in a rapid sequence of by a few days. So this happens, across the world, as I said. Why are children at greater risk? Another reason is that in pediatric practice, the off-label use of drug is very common. And when you are using the drug, off-label drugs, you will see that percentage of errors increased. Unlicensed drugs are being used. So, for example, in COVID times, nobody, ICMR or no agency, WHO or CDC, nobody has recommended use of remdesivir, chloroquine, or any such drug for pediatric age group. However, I have seen people using these drugs. How much of benefit they cause, I don't know. But the potential to cause errors and harm because of those drugs is huge. So 13% of the errors, they can cause moderate harm, whereas 60% of the unlicensed drugs, when they are used for pediatric practice, they can cause harm. So unlicensed drugs should be avoided as far as possible, and they are responsible for significant amount of errors. Again, children can't always tell us when they start developing symptoms, and therefore they are at higher risk of suffering from moderate or severe illnesses. And sometimes this is also a phenomenon I've seen. You prescribe a syrup that is too tasty, and sometimes child gets a bottle and takes whole of the medicine. So paracetamol poisoning because of the tasty brands is very, very common in our setup. Usually it does not cause severe harm, but it has potential to cause serious harm. Children have less internal reserve, and with which to buffer the effects of errors, and therefore that becomes a So how to prevent it? Basically, if we have a reporting system, and for individual practitioners, I say you note down your own errors. You don't have to show to anybody. It's not necessary to show to anybody, not necessary to report to any agency. Just note it down in your diary, and once you note it down, you will see that you will not repeat it again. Then review of errors, identification of system weakness, change of policies and procedures, and then feedback to staff. And the feedback has to be given in a way that it does not have a punitive nature in it. So it's important to know the drug, rules regarding zeros and decimal points. So you have to write 0.5 but not 5.0. So that is the decimal rule. So ready to access pediatric drug dosing should be available in all the ward. Avoid calculations by use of standard doses or doses charts. Drug monographs have to be read, and individual emergency drugs have to be given properly. Check weight every time the child comes to you. Ensure that the doses when you calculate are not more than the standard adult dose, because that is usually the maximum permitted or usual maximum permitted dose. Do not accept poor or ambiguous prescriptions. Accurate patient history taking involving the family and allergy history, etc. is important. Avoid interruptions. Do not take telephone calls when you are writing a prescription, or don't write prescriptions simultaneously while you are talking on phone to somebody. It's good to have a quiet room or a medication nurse and technicians who can, explain and also check the medications errors. Root cause analysis of all medications errors are very important. So to summarize, what I will say is that acknowledge that this problem does occur, be on a lookout for the problems. Once you have done it once, record it for yourself so that you don't repeat it. Once it is in your conscious mind, you will not repeat it. Cease finger pointing. Do not say that this doctor has done or he's a fool, this sister has done, she does not know her job. That kind of thing does not work. They become defensive and you will not know medication errors when they are occurring. Always be supportive and find out the systems that are responsible for this by analyzing all the errors and evaluate proposed solution and implement them. Establishment of a review scheme is very important for a hospital. There has to be a no blame system. It's not somebody's fault that a medication error has occurred. People do not do it deliberately, I say again and again. And suitable pediatric references should be used. Uh, any system that helps prevent the medical mistakes by helping doctors come forward without fear of having a punitive action should have or hold a real benefit for NHS. And this is from the chairman of British Medical Association. So the system should try to help. And thank you for the patient listening, and I'll be happy to answer any questions. Shall I stop sharing this presentation?
Thank you, Dr. Mishra.
Thank you, sir. Thank you so
Question
much.
sessions will be at the end. Thank you very much for taking this very eye-opening session of benefited by this. Now, our next speaker will be Dr. Vijay Tyagi. He is an anesthetist from Dehradun, Uttarakhand. He is also LLB, PGDMLS. He is member in IMLEA and he is past secretary of Dehradun IMA. His topic for today is anesthesiologist during COVID. Dr. Tyagi, please go on.
Yes, thank you, Dr. Siroy sir. Thank you, Dr. Siroy sir and Dr. Anurag for this opportunity.
Dr. Tyagi, your voice is not so clear. Please make it loud.
Thank you, Dr. Siroy and Dr. Anurag for this opportunity.
Increase the volume, Doctor.
I'm starting it. Just a moment. Volume.
Yes, please increase the volume.
It's full almost, sir. 100%.
Okay.
Is it audible?
It is audible, but less audible.
Okay.
So that it is good.
100%. Okay.
Yes, now it is good.
So, anesthesiologists during COVID-19, it's really a tough time for all because of Corona. We know health professionals are suffering and are more at risk. And I will say among all specialists, few are more at risk. And in that case, for sure, anesthesiologist is at top. COVID-19 time practice has seen many changes in the different specialties, like avoiding positive patients, maintaining social distancing, screening at the entrance hospital. While avoiding positive patients is easy and still happening in most of the hospitals, treating them at head end, it's nicely and bravely done by anesthesiologists around the globe. Anesthesiologists are posted in at all corner of the hospital in COVID-19 duty, right from the PSC clinic, IC, operation theaters, and even sample collection. And specialists in these critical areas are mostly anesthesiologists only. Anesthesiologist risk is more because he's handling the storehouse of the virus, or that is airway, right from the airway assessment to intubation and extubation. Intubating a patient with the PPE is really difficult. It's a tough job. And even a simple intubation with mask, shield, specs, goggles, we know it. And intubating a difficult patient with PPE on who is desaturating is a simple nightmare. After successful intubation also, the expiratory wall anesthetic, which is a danger zone. So they are more at risk each and every time. The role played by anesthesiologists in COVID-19 is mainly they are front runners, protectors, savers, in and end by just like critical care physician as pain physician. It was more relaxing role observed by the fellow anesthesiologists who are doing physician practice, simply doing OPD, avoiding positive patients. It was most relaxing. Take the challenges as the first line responders. They risk their life in providing anesthesia to emergency surgeries of the positive patients and in ICU, endangering their own life and the family members' life with the sleepless nights. But they lost their life also. According to Indian Society of Anesthesiologists, more than 600 anesthesiologists got infected while performing their duty, and about 15 lost their life also. And this number is highest among all specialties. And this number is while they were on duty, not because all affected outside their duty. Many freelancers lost their job as the work was limited. People were avoiding, nursing home were avoiding outside anesthesiologists. Many lost it. It was a tough time, many anesthesiologists. I've seen it personally also. COVID-19 also brought something positive for the anesthetists, something positive. That was job satisfaction and very much awaited recognition among the medical fraternity and the society. Now we see in the society people are asking about the anesthetist. Who is he? Where is he? His name. They know by name also. For the first time, they are in huge demand. About the anesthesia, treat every case as a positive case with the standard precautions. Regional anesthesia is much safer for the patient and the OT staff. Keep yourself protected while giving anesthesia and ICU duty. Never put your guards down. And finally, no more heroic effort for the patient by putting your own life in danger. As battle is still going on and it's difficult and it's a long way to go. We have seen a story of Dr. Sanket Mehta, who was anesthesiologist in Surat and admitted in ICU. One patient was desaturating and he himself got, he was infected with this COVID. So he went without BP and intubated that patient. His life was saved, but Sanket Mehta was in bad condition on ECMO for 15 to 20 days. And finally, he was out of it. Some hospital in Chennai. His life was saved, but that effort was a heroic, and that is not the right way. This is my personal opinion. Just as we can see, all are sleeping. This child who is enjoying life, he can be a future anesthetist. This is a simple message. This is multitasking effort done by an anesthetist, surgeon,
so many things to do, and the physiologist faces, he doesn't have a time to react. Very limited time, 30, 40, 50 seconds, maximum 1 minute, and he has to respond in that manner only. Right. As a pain physician, I can simply say a message: the freedom from the pain is not a privilege; it's your right. Thank you. Thank you very much. Thank you, Surgeries, sir.
Thank you, Dr. Tyagi. Rightly, anesthetists have been recognized in COVID times. They have done a lot in ICU, intensive care units, and they have fought like anything. We all recognize them, and thank you very much, Dr. Tyagi.
Thank you, sir.
Our next speaker is Dr. Himanshu Kochar. Dr. Himanshu Kochar, please share your screen.
I'm doing so.
He is an orthopedic surgeon at Max Super Specialty Hospital, and his area of interest is orthoplasty and arthroscopy.
I will be, thanks for this opportunity given by Dr. Siru. It's a nice platform. I have listened to all the talks and they were very interesting. And the medication errors, yes, they are a big concern. At our hospital, we have a computerized patient recording system. So there is nothing in writing. And still the errors happen sometimes, like the medication which is to be given by a epidural route, that is levobuprofen. It was given IV and it's a sure shot death. So such can be prevented by meticulous, you can if you are vigilant about all these things. So today I will be talking about osteoporosis, which is a pertinent topic for everybody. It's a silent epidemic with overwhelming proportions. This bone health, everybody talks of cardiac health and other part of the health, but nobody talks about bone health. And recently we are seeing lot many cases of fractures. They are osteoporotic fractures. Even the people who are in 40s, the bone strength is like that, like it's just like a paper. Like this, the WHO has warned that the most of the fracture cases with the turn of the decade will be in India and China, because they are the two most populous countries and the infrastructure for screening the osteoporosis is meager. So it's a disease of modern civilization. The basic thing is that on the basically the left hand side you can see is the normal bone, and osteoporotic bone has there's a quantitative reduction in both the cortical as well as the cancellous bone mass. There is a concept of peak bone mass which is not being followed in India. By the year 30, like we assimilate, our bones assimilate calcium and they grow. After 30, at a particular rate, that is around 0.5% per year, the bone decays. And during the post-menopausal period, the ladies may lose up to 1 to 3% of their skeleton per year. So it's a good chunk of bone which is lost in the post-menopausal years. And secondly, like if we optimize the peak bone around 30 by supplementing or by fortifying our foodstuffs with calcium and vitamin D supplementation and with an active lifestyle, this can the peak bone mass can be optimized so that they fare better in the later part of the life. By definition, osteoporosis is that when the bone density is less than minus 2.5, and when it is -1 to -2.5, it is deemed as osteopenia. In bone metabolism, there are two types of cells, that is osteoclast, which erodes the bone, and there is osteoblast, which forms the bone. So there are newer pathways which has been recently being come into vogue, like Rank-Rankle pathway, which acts on the osteoclast, and there are other pathways for which acts on the that is WNL pathway, which acts on the osteoblast. So what is the difference between osteoporosis and osteomalacia? Most of the people confuse in that. In osteoporosis, there is no defect in the mineralization. But in osteomalacia, because of the vitamin D deficiency, there is a defect in the bone mineralization. You can see that there is a large part of the bone is unmineralized, and usually the mineralization is normal in in osteoporosis. Only the bone mass is reduced. Here also the bone mass may be variable, but the mineralization is poor. So if we go to the clinical features, usually they present with the pain. It is usually pertaining to the trivial fractures, mainly spine, hip, wrist, loss of dent. Usually the dental surgeon usually maybe the earliest person to pick like because of the loss of the dentition. Usually there is upper dorsal pain, pain in the lower rib cage, and the lower back pain also is a common symptom. Usually this picture you have seen in textbooks, that as the lady ages, there is a loss in the height of the lady. There is a kyphotic deformity which develops over the period of time. Investigations usually in this, the calcium, inorganic phosphorus, they are normal. Near menopause, there is a slight hyperphosphatemia. Serum alkaline phosphatase is mildly raised. Hypercalciuria is found in 20% of the postmenopausal females. Now, this slide I have put because recently, because we have to monitor our therapy, like the treatment which we are giving. Recently, these two things for bone formation, this is propeptide type 1 of type 1 procollagen. This is one which is being studied, and then osteocalcin being studied, and bone specific phosphatase. These are bone formation markers, and bone resorption markers are C-terminal telopeptide of the type 1 collagen, N-terminal telopeptide of type 1 collagen, and deoxypyridinoline. These are the markers which we can study that how much bone is getting resolved and how much bone is getting formed. So we have to decrease the bone resorption, and we have to increase the bone formation. In radiology, you can see that there is an increase in the vertical striations. There is loss of the horizontal striation. There is, you can see there is a collapse of the vertebra, wedging of the vertebra. This is a newer classification which has come up, that is by Sugita et al. They divided the compression fractures into 6 types. This is a normal type, a concave type where the superior end plate is buckled in, a dented type where the anterior cortex is buckled. There is a swelled front type where the anterior cortex is bulged forward. And there is a type, this is known as bow shape, where the superior end plate is buckled in, and there is an anterior cortex is also breached. And there is a projecting type when more than 50% of the anterior wall is projected outward. So I will put up an X-ray, like if I can ask Dr. Sirohi only, what will you do with this fracture? This X-ray this evening only. This 63-year-old guy, he has fallen in Visakhapatnam, and like there the surgeon has advised something. So how many of the people will go conservative with this, and how many will go with the will observe it, like Dr. Sirohi?
I will go conservative.
Sir, because this is a high risk fracture. This is a bow-shaped type. The superior end plate is also fractured. The anterior cortex is also indented. So these patients should be followed up with the serial X-rays. If there is a loss of more than 50% of the height of the vertebra, it should they should be intervened and they should be operated. A kyphoplasty should be done so that the height can be maintained and the pain can also at the same time be elevated, because these are unstable fractures and they may progress also. So they should be followed up serially on the serial radiographs. DEXA scan, usually it is ordered for the two sides, hip and spine, and it's a common investigation. It has a low radiation, short scan time. The only pitfall is in the degenerative spine where the osteophytes can give false positive, false positive reading. In DEXA scan, there are two scores. T score is when the comparison of the person's bone density is a healthy 30-year-old of the same sex. And Z score is the comparison of the person's bone density with that of an average person of the same age and sex. So you have to see both the scores, but commonly people only quote T score. MRI also gives the information about whether the fracture is, depending upon whether it's acute or a chronic. It can tell about the retropulse fragment or any cord indentation. It can also tell about non-union of any fracture. Then it can also secondarily tell about the any malignancies or any metastasis or cases of multiple myeloma. So MRI can also be informative in these cases. Mainly the treatment is medical. Usually these basically the fractures and the osteoporosis go underdiagnosed and undertreated. Recently, there is a stress on the sequential therapy, needs early intervention. We should educate the community. They should be sensitized regarding bone health. Pharmacotherapy is the mainstay in the treatment of osteoporosis. If one fracture happens, the second is on the way. So once the fracture has happened, patient should be put on the basically anti-osteoporotic treatment. So the issues are, there are several confounding factors. There is lack of knowledge even among the healthcare providers. Compliance to the treatment is poor, and long-term treatment, the safety is a concern. Drug therapy is indicated in all post-menopausal women with a vertebral or a hip fracture. Any patient whose BMD values are in the reading of osteoporosis, that is the T scores are more than -2.5 or -2 to -2.5. All patients must get recommended dose of calcium and vitamin D. So, because in India, the bone density machines are not in the periphery, the bone density machines are not there. So, even in the countries where the infrastructure of the bone DEXA scan is not there, this WHO came up with the FRAX, that is the Fracture Risk Assessment Tool, for the use of estimating 10-year probability of a hip fracture as well as any other major fracture in untreated patients of osteopenia. FRAX calculate the fracture probability in the individuals from the age, bone mass, body mass index, risk factors. The risk factors are any prior fracture, parental history of hip fracture, current tobacco smoking. I don't know how many of, like many of the surgeons do smoke. Smoking is bone terrorist. Like this is a term which is given, bone terrorist. Overuse of long term of steroids, rheumatoid, secondary osteoporosis related to many other drugs like anti-epileptic drug, hypothyroid drugs, all those can cause osteoporosis or penia. And regular alcohol consumption, occasionally is fine, maybe 2 drinks a week, but if you are a regular alcohol drinker, that can also lead to decrease in the bone density. The therapeutic interventions are recommended if the 10-year risk of the fracture is more than 20% for any major osteoporotic fracture or more than 3% for hip fracture. This is just a bone metabolism. There is to tell that this rank-rankle pathway, this is recently being studied, and we have a monoclonal drug which acts on this pathway, and it inhibits and regulates the activity of the osteoclasts. This is the osteoblast, which is forming the bone cortex, and this is the osteoclast, which is removing the bone. So we have to reduce the bone resorption, we have to increase the bone formation. The management of the osteoporotic with fragility fractures. So before instituting the management, we should investigate thoroughly we should investigate the patient thoroughly. That BMD by DEXA scan should be ascertained. Serum calcium and alkaline phosphatase should be done. Vitamin D level should be estimated. PTH, TSH should be estimated. Serum proteins and creatine clearance is very important, especially if we are giving bisphosphonates, because they are metabolized, they are excreted through kidney. For monitoring therapy, repeat BMD estimations are required, and bone turnover markers, which I have already discussed. So the first drug which I will be discussing, it's teriparatide, that is recombinant parathyroid hormone. The positives of this is that it induces osteoblast stimulation, effect cortical as well as the cancellous bone. It is known as wonder molecule, enhances bone architecture, and it is effective in fracture cases, in which if we have interdraw fractures, we can put the patient on teriparatide, and it will help in healing of that, the healing of the fracture. The negatives of this thing is that it's a subcutaneous injection. It is high cost. The duration is usually long, like around 8. You have to give for 2 years, and that is the maximum that you can give. Cold chain is an issue, like the transport of that injection from the vendor to the patient. And serum calcium and PTH to be monitored. If inherently because of any reason there is a hyperparathyroid hormone is raised, then you can't give this teriparatide. And there is a concern about increasing the chances of malignancy, but there has been no report of increased like such risk in humans, basically. Bisphosphonates are the mainstay of the treatment. They are the most commonly and widely used drugs. They increase matrix mineralization, but to a certain limit. Cannot restore lost bone or substantially improve the bone microstructure. Close resorption pits have effect on osteoclast, no effect on the osteoblast. Compliance with these drugs is a major issue because it's a long-term therapy. So the positives of bisphosphonates are that they can be taken orally or they can be given IV. They are cost-effective as related to the other modalities. Alendronate is most effective orally. Ronendronate is most effective when given IV. They have an effect on osteoclast. They have an apoptotic effect. So they have also role in giant cell tumors. Like after giving 3 to 5 years, one should give a drug holiday of 6 months to 1 year. The negatives of bisphosphonates for oral salts is that it can cause esophagitis. They can affect with the bone remodeling. That means the bone turnover is suppressed. This explains the jaw necrosis and atypical femoral fractures. High dose, prolonged use mainly, and potent IV salts can cause these complications. One should have to adhere to the precautions. That means one have to take it empty stomach if taken orally, need not to lie down for half to 1 hour, and to have to take with 2 glasses of water. Sometimes the patients are not able to take 2 glasses of water at a time. And with the IV injections, they have to be taken yearly, and you have to remember that when you have to take it again. Denosumab, this is what is newer drug which has come up. This is a fully human monoclonal antibody that binds rankle, prevent rankle from activating rank, its receptor on the osteoclast. So that reduces the bone resorptive activity. With reduced rank-rankle binding, osteoclast formation, function and survival are inhibited, bone resorption decreases, and the bone mass increases. The cortex of the bone is the prominent role in the strength of the bone, and this explains that with osteoporosis, there is a high chances of fractures, especially in the proximal femur. Denosumab, for its mechanism of action and pharmacokinetics, results in significant early and continued increase in the BMD with enhanced bone strength improving both cortical and the trabecular bone. So it has effect on both cortical as well as the trabecular bone. The denosumab, it has a 6-monthly scheduling. That means it has to be given a 6-monthly injection. The 10-year follow-up is, studies have been published. 15 years will be soon available. No lab test is required. After all skeletal sites, it affects on all the skeletal sites independent of the trabecular cortical bone ratio. So, and it also have a quick response and it is safe in malignancy. The negatives are that it has to be given injectable. The cost is really high. It is 13,000 the injection, 1360 milligram. Bone density reduces rapidly on cessation of the therapy. Fracture risk increases. That means that if like we stop this denosumab, the bone density again starts reducing. So after the stoppage of the denosumab, one should start the bisphosphonate so that there is a follow-up of the bone density which is the bone density which has increased because of denosumab is maintained with the bisphosphonates. Other drugs which are available are calcitonin. It is recommended for postmenopausal osteoporosis treatment, but not for the prevention. It is only given for pain relieving in vertebral fractures for short term only, maybe 2 months or 3 months. These are another class of drugs that these are known as selective estrogen receptor modulators. The raloxifene is one which is given 60 milligram daily. It reduces the basically vertebral risks in postmenopausal women with osteoporosis. It also reduces the risk of invasive breast carcinoma. It has an increased risk of venous thromboembolism. This is usually given in the patients which are perimenopausal, like just after the menopause, who are active, in which the chances of VTE is less. This bazidoxifene, this is a SCRMs which is not presently available in India, but they have optimized it for the skeletal and the optimized its skeletal and the lipid profiles. So osteoporosis, DEXA, and the risk factors. If one has a fragility fracture, then teriparatide is the choice. If one has an osteoporosis without a fracture, then bisphosphonates or denosumab is the choice. So this is a chart, just a nutshell in revising all the things. Teriparatide, it is to be given maximum 2 years. And this can be given only for once in a lifetime, but some people also repeat this teriparatide for another 2 years, but usually it is advisable that it is to be given only once in a lifetime. It's a subcutaneous injection and needs serum calcium and the PTH monitoring, and the risk of malignancy is there, like it's a question mark. Bisphosphonates usually can be safely given for 3 to 5 years. Oral and IV salts are available. Compliance is an issue with bisphosphonates, and it has an issue of jaw necrosis and atypical fractures, because these atypical fractures are usually subtrochanteric fractures in the femur, and they are very stubborn to the like basically treatment. They don't respond to bone grafts. Ideally, you have to open up that fracture site, remove that segment of the bone, and then graft it and nail it at the same time. So these fractures are difficult to treat. Denosumab, 10-year, yes, it has to be given for 10 years. Thus, the injection should not be stopped because then the bone density start decreasing. It's a subcutaneous injection and there is no risk of malignancy. 1 + 1 is not equal to 2. Combined effect is being investigated. If you have given teriparatide and then you can follow up with bisphosphonate. If you have given denosumab, you can follow up with bisphosphonates. But if you have given teriparatide, you can follow up with denosumab. But if you have given denosumab initially, then you cannot revert back to teriparatide. So comparative effects of the teriparatide, denosumab, and a combined effect. So these are recent studies, 2015. They are showing that together these findings suggest that use of denosumab and teriparatide in combination improves HR quantitative CT measures of bone quality more than either drug alone or maybe of significant clinical benefit in treatment of postmenopausal osteoporosis. Combination, combination of denosumab with high dose of teriparatide, that is routinely 20 microgram is given, but here they have used, it's a basically a randomized phase 4 trial. Combined treatment with the teriparatide 40 microgram with denosumab increases spine and hip BMD more than the standard combination therapy. This large and the rapid increase in the bone mass suggests that this high dose regimen might provide a method of restoring skeletal integrity in patients with severe osteoporosis or osteoporosis. So they should be picked early. Bisphosphonates are the choice of drugs. Oral and IV salts are available. Drugs may be region specific, like some are effective more on the hip region and some are more helpful in preventing the osteoporosis, like in treating in spine. BMD of all bones the same way. Can we stop the medication? No, you cannot stop the medication because once it stays there. You have to treat it and monitor it. Calcium and vitamin D supplementation is very important. After treatment, the BMD should be re-estimated on a yearly basis, and regular follow-up is the key in the treatment of osteoporosis. This is new term which has come up, that is sarcopenia. Sarcopenia and osteoporosis. What is sarcopenia? Sarcopenia means as we age, with the reduction in the bone mass, there is also reduction in the muscle mass also, because with bones the muscle unit also works in tandem, like it works with the bones. So there is a reduction in the muscle mass and there is a reduction in the bone mass. So people are saying that osteoporosis and sarcopenia, are they two different diseases or they are one disease? This is the MRI of a, you can see, young thigh, and this is the sarcopenic thigh. You can see that the muscle is shrunken and it is replaced by, usually it is replaced, infiltrated by the fat, and the girth is also reduced. So now the term which is the newer term which is coming up, that is postmenopausal sarco-osteopenia. So the acquired factors involved are genetic, aging, estrogen levels, menopausal transition, exercise or physical activity, body composition, and vitamin D levels and levels or intake. So it leads to osteopenia, osteoporosis, decline in the BMD and increase in the fracture risk. And sarcopenia, decline in the muscle mass, strength and the physical function. All these interact, this mechanostats, estrogen and physical therapy, and this leads to falls because the muscles have also reduced and the bones are also weak. So it leads to frailty, disability, mortality, and it adds to the cost. So this is a vicious cycle which starts with the aging. So now the therapies are being targeted to target both the things simultaneously. So there are many unanswered, there are issues which are not yet answered. Patient education is a concern, and awareness too, and adherence to the treatment. Osteoporosis, resistance to the osteoporosis might be there. Usually the resistance to this bisphosphonates is not known, but there is a theoretical risk of that certain patients don't respond to any treatment. Then atypical fracture and jaw necrosis is a concern. Cost and the parental administration is a concern. We don't have any India-based data. There are social issues to it. And studies usually which are published in standard like journals, they do have because they are all company driven, they have a conflict of interest also. So the take home message is one should start early treatment, stress on education regarding bone health, insist on regular follow-up and adherence to the treatment. One should discuss sequential therapy, that once you stop one drug, you have to follow up with some other drug also. identify the risk factors, and lifetime modification should be instituted, and one should pick dropout cases and they should also be treated. So oral calcium and vitamin D, one can continue for lifetime, but vitamin D is a fat soluble vitamin. It can cause toxicity, and giving calcium, it is debatable, especially for the cardiac patients. Teriparatide maximum can be given for 2 years, and like if it is to be repeat dose can be given, like some people say that it can be given, but once it is stopped, it should be followed up by a bisphosphonate, that is an anti-osteoclast agent. Denosumab can be given for 10 years, but BMD drop after stopping the drug, so it should again be followed up by a bisphosphonate. Bisphosphonates can be safely given for 5 years. Then a drug holiday should be given, and atypical fracture is a concern. Combination of drugs, yes, the evidence which is coming is promising, but more studies are required to validate that. This brings the end to my talk, and it is open for discussion and any questions if required. Yeah.
Thank you, Dr. Himanshu. Such a nice presentation of osteoporosis, the silent killer, and the Danusab. I would ask a question: how much is Danusab being given in metros these days? It has been started in Dehradun?
Yes, sir. I have personally used denosumab in many patients, especially in patients which have been treated for some malignancy, say breast carcinoma or anything. It is safe to give denosumab. It's a 6-monthly injection. It is 60 milligram dose subcutaneously, and it can be also used basically to, if you have a giant cell tumor and it is a big tumor and you want to shrink the size of that tumor, so it is also efficacious because this has an anti-osteoclastic activity, so it acts against the giant cells. So in GCT lesions also this can be given, like in double the dose which you use for the osteoporosis. And the only concern with the drug is the cost. It comes up, it's costly basically.
Yes, for shrinking the giant cell tumor, it is very good. I have also come to know it.
In pelvic.
Thank you, Dr. Himanshu. Please unshare your screen so that others may come.
Sure, sir. Sure.
On the. Okay. So now the session is open for discussion. I would ask the panelists also whatever they have to ask. Dr. Anurag, Dr. Rishi, Dr. Jagdi, and all the speakers also can ask questions to one another. Dr. Anurag, you have something to ask?
Yeah, definitely. First of all, I extend my sincere thanks to all the speakers and the panelists who have come here for this webinar. IMLEA and IMA Uttarakhand, both are very much thankful to them. And now I would like to ask one question from Dr. R.K. Sharma, who has presented his topic very well. There is a controversy, Dr. Sharma. Can you please enlighten us or actually clear this misconception or whatever you may call it, confusion, that why patients taking ACE inhibitors or ARBs they are at risk from COVID-19? Is it true or not?
Dr. Sharma, you have to unmute yourself.
Dr. R.K. Sharma, please unmute yourself.
Okay.
Yes.
Can you listen me?
Have you listened to me, whatever I said?
Yes, I have heard you. See, the person who are on ACE inhibitor or ARB, there are receptor sites present in the lungs and kidneys and even in myocardium. So once they are put on ARBs or ACE blockers, they proliferate the receptor sites. They are having more receptors than what others are having. So because the virus have a spike protein which gets attached to ACE receptors on the cells. So theoretically speaking, they are at more risk because they are having more receptor sites to attach to the spike protein of the virus. But there is no scientific evidence that patients who are on ARVs, they are having more complications than the normal population. So it has been recommended that patients who are on ARVs should continue to take their drugs as they were taking earlier to control their blood pressure rightly. So I don't think there has been any contraindication to use ARVs or ACE inhibitors during COVID infections.
Thank you.
I hope your answer is clear.
Yes. Thank you.
Thank you, Dr. Sharma. Dr.
Dr.
Jaggi?
Jaggi asked for.
I just want to talk to Dr. Sharma. Very nice presentation and very nice makeup of his slides. Beautiful. So he had in his talk said that don't use ibuprofen. So I want to ask him, why do you say that you don't use ibuprofen when the patient is having COVID?
There has been a recommendation that ibuprofen might induce some bleeding diathesis, platelet dysfunction in other diseases. As far as the virus COVID-19 is concerned, there has not been much studies on ibuprofen. So I don't think they have taken feedback from other studies.
There is no scientific evidence otherwise.
No, not yet.
And what about the relationship of hypoglycemia with HCQ, hydroxychloroquine?
Yes. Hydroxychloroquine is a drug which causes hypoglycemia because it is being used as hypoglycemic agents in the diabetes as well. Hydroxychloroquine or chloroquine are the drug. They act on the insulin receptors and they increases the effect of the insulin in the cellular level. So they causes hypoglycemia as well. So they are sometimes used in diabetes. When the diabetes is not controlled, they are put on hydroxychloroquine or chloroquine-like drugs to control the diabetes as well. So this is a good hypoglycemic agent. And sometimes in our discussions, we have used it. I personally have experience of using hydroxychloroquine for diabetes.
And you get good results?
Yes, it is.
That's great. Thank you.
Sir, the reason for not using ibuprofen in any viral disease in COVID-19, usually all the NSAIDs should be avoided in fevers, in viral fevers especially, because they can lead to acute hepatic nephritis, Rh syndrome, or they can land up into this Guillain-Barré syndrome also. So all the NSAIDs
in Maharashtra, 20 cases of Guillain-Barré have been reported post-COVID.
So because of this, I think the NSAIDs in general way in any viral illness should be avoided.
So question to you,
because
sir.
it is seen in
question to you, Dr. Kochar, since you were talking just now. Anything to prevent sarcopenia?
Sir, it's an aging process. Like the recommendations are that a regular exercise. This is propagated by WHO also, that 30 minutes of weight-bearing exercise most of the times of the week. Maybe right, you can take 2 days of off, 5 days of moderate exercise, and moderate exercise comprises of in which your heart rate increases a little bit. That means a brisk walking, cycling, they are all moderate exercises. And they have also said that the exercises should be weight bearing. Sometimes people say that I cycle for around 5 kilometers, but cycling will not increase your bone mass and at the same time will not help in building up the muscles. if you are doing a weight bearing exercise, that will be more helpful. So exercise, physical activity, that is been propagated to prevent the sarcopenia. But it's an aging process, like you cannot stop. Like with age, it will happen.
I want to ask one question from Dr. Kocher at this very moment. You told that smoking is also related with osteoporosis, and you said the surgeons are there very fond of smoking. So this is not smoking is not limited to surgeons only. I should tell you it is.
No, sir, it was just
When
a
I,
just a
but
comment.
I want to ask one question, that how smoking is related with this osteoporosis.
Or it wrecks the bone like it
And up to the extent that it is called terrorist.
yes, it is quoted, sir, by
Why?
the National Osteoporosis Foundation. The term they have coined it is as bone terrorist. Bone terrorist means that like the bone is becomes very problematic in smokers. Like sometimes we get individuals like 20 years old individuals, and if you operate them, you find the bone is very osteoporotic. Yes, sir.
Dr. Kocher, you talked about teriparatide, biphosphonates, you talked about dislinzumab, calcitonin. What is the maximum age group in which you can start this treatment? When should the treatment with these drugs started? Can it be started in an 85-year-old person?
Sir, I told you that like any postmenopausal female who has a bone density more than -2.5, the treatment can be started. Usually the people come to the hospital only after a fracture. So once you have a fragility fracture, and after the treatment, most of these people are lost to follow up, they don't come back. So they are not put on the any anti-resorptive or osteoporotic treatment. So
So there is
even at
no age
85
bar.
years old, yes, it can be given, sir.
Okay, okay. Thank you.
Actually, I wanted to ask one question from Dr. Satish, but he is not at the moment there.
I am very much over here.
Dr. Satish is there, Dr. Anurag.
Sir, I am listening everything.
Sir, if you vaccinate a child during the period of corona, then will it lead to more susceptibility to other infections?
Sir, very pertinent question, because the basic principle of vaccination is that the immune system, it gets directed to the antigen induced. Like the basic principle of vaccination is we take out that organism, we take out that antigen component of the organism and induce in the body as an artificial infection. And the body makes antibodies against that organism or the component of that organism. So if a defense system has been directed to that particular antigen, so obviously logically then body becomes susceptible for other infections to occur. But there is no such evidence to prove this hypothesis. So in corona pandemic, all the vaccines may very well be given to the child, and it doesn't make the child susceptible to any other infection.
So this way I can correlate this with the in case of adults also, that vaccination in adults can also be done for
Sure, sir.
they require.
And it has been true, if this vaccination adults, they do decrease the mortality and morbidity in adults. Even Dr. Sharma sir said if they are immunized against influenza and pneumococcal vaccines, so this delayed complication secondary bacterial infection may very well prevent even in corona also. So it is advisable. And in other countries where the fertility incidence is high, even the adults are also advised to get vaccinated against this fertility component also.
Sir, can a person who is COVID positive, he can be vaccinated? Because in some other vaccinations, like for rabies, if the person is having fever, then directions of the just the doctors, they avoid giving vaccination at that time. So this is, I think it is very, very pertinent to ask at this point that if a person is infected with COVID infection and he requires vaccination for some other disease, then can he be vaccinated or?
Sure, sir. Now, there are two situations. If the person is infected with COVID, either he is isolated at home or he is admitted in a healthcare facility. So, if it is isolated at home, so vaccinating at home will increase the susceptibility of other persons to get infected. So, it is advisable not to give vaccines at home. But if the person is admitted with as a COVID patient at healthcare facility, so once he becomes asymptomatic and his two successive tests they turn out to be negative, he can very well be vaccinated at the healthcare facility itself. Or in case if the facilities are not there for testing, so at least 14 days period should be there after the last symptom for vaccination. So there is no contraindication for the COVID patient also to get vaccinated.
Sir, Verma sir, can I add something to this? Now, when a person is COVID positive, you can certainly give a vaccination that is of the rabies type, because rabies has 100% mortality. There is no saving from rabies, whereas COVID patients, the mortality, as told previously in one of the talks, is much less. The precautions that you should take, definitely the face mask, definitely the face shield, the eye cover is required. You can wear a PPE, you can vaccinate at home. But one thing that I would like to tell, that to such a person, you don't face him face to face. The person should be facing on the other side, and you can give the vaccination in the deltoid or thigh, depending on the age of the person. We prefer a deltoid side for adult and thigh for the smaller children. So basically, the contact time in giving an injection is less than 1 minute. We know for COVID transmission, the contact time has to be 15 minutes or more than 15 minutes is dangerous. So that contact time should be reduced. All the preparation should be done, and then the person should be asked to enter the room and take the vaccine quickly and move out in less than probably a minute or so. And therefore, with adequate precautions, there is no harm vaccinating, even at home, I would say. Although the recommendations, as Dr. Satish has already said, that recommendations are not to vaccinate at home. But for something like rabies, one has to give vaccines. There is no escaping from that, because rabies has 100% mortality.
I thought Sir has given an example of rabies. You were not asking about the rabies vaccination. Because I thought so.
No,
Yeah.
Dr. Satish, for other vaccinations wherein the mortality is not 100%, you can still wait and give vaccines after 10 days. That is not going to cause much of the harm. But rabies is a disease which has 100% mortality, and therefore you cannot delay the vaccination for rabies.
Even the monoclonal antibodies they are to be given.
Monoclonal antibodies are also to be given. So rabies treatment has to be completed.
Sir,
it has to be very aggressive. Yeah.
Sir, can I ask one question?
Yes,
sir,
please.
Sir, for Dr. Sudeep, rabies, the vaccination is given for the prevention of the rabies.
Yes.
Yes, it is a 100% mortality, but in a rabies scenario, like usually it is given to prevent rabies, because once the rabies has happened, it has 100% mortality.
Yes.
Okay, so the vaccination is being given to prevent rabies. The vaccination should not be administered at the type of a febrile illness. Once the patient is afebrile, the vaccination which is deemed can be given with due precautions, I think. That's what my belief, or which is.
So,
what he wants to say is that due to COVID, this should not be prolonged up to a more than to a desired extent.
Patient should not be in a bout of fever. Then the vaccination should be held. Once the patient is afebrile, if the vaccination is due and it is required, it should be given. I think.
No, take on my take on that is that if the person is febrile and is coronavirus positive, COVID positive, the fever is very likely to be because of the COVID rather than because of the rabies. So if the person suffers from a bite and has fever and corona, I would still say that you continue to give the vaccines.
Correct. I agree.
Himanshu sir, if you talk about rabies, so as you rightly said, it is the active immunization which we are given by vaccines. And as Dr. Mishra sir said, monoclonal antibodies are the passive immunization. So it is the ready-made antibodies we are giving to the patient of rabies. If the, as Sir Mishra sir said, if the person has been bitten by the dog, so without wasting any time, without waiting for anything, we administer vaccine as active immunization and monoclonal antibodies as passive immunization. But they are the ready-made antibodies. I think I am clear.
Like in a lifetime, have you seen a rabies? Just a question.
I didn't get you.
Have you seen a rabies?
In a lifetime, have you seen a full-blown case of
Yes,
rabies?
yes, we have seen. We have
Sure,
seen.
sure,
We have
sure,
seen
sure.
many
I've seen
cases.
many
I have
cases.
seen many cases.
Many cases of rabies.
So how many of what is the mortality? How many of them survive? Any one
No,
of them
no.
survive actually?
It is said.
Worldwide,
It is said that about
worldwide, Dr. Kocher, worldwide, there is only one possible survivor where the diagnosis of rabies was, not 100% sure. That is only one survivor in the whole world. Rabies, there is no survivor once it gets infected. 100% mortality.
Monoclonal passive antibodies. Is there any chance that the patient of rabies, full-blown rabies, will survive?
No. It's once the rabies virus attaches to neurons, then nothing can work. Nothing works as of now. I can't say nothing can work. Future, you don't know.
So we are actually talking about a case of a dog bite. Should he be vaccinated if he's having fever or not? We are not talking about when rabies has already developed. So we are talking about this scenario.
So you can't say at once whether rabies has developed. If the dog has bitten, you can't say at once the rabies has developed. So presuming that rabies is settling in, as Dr. Mishra sir said, so without settling the virus going to neurons, we have to wash out the area properly with soap and water. We have to clean that area. We have to give monoclonal antibodies locally, and we have to give active immunization.
So
and
if
once
the patient
rabies is settled in, yes sir.
So the question was that if the patient is COVID positive and he's bitten by a dog, do you go with the normal regime of vaccinating him for rabies also?
Yes.
Sure. 100%.
So this answers all the questions. So you have to. So one thing, my eminent pediatricians, please let me know that why these small children and all, even if having infected with COVID, do not manifest this disease. They act as carriers, they spread the disease, but they do not manifest. And absolutely, there is no mortality. What is the reason?
No, first of all, it is not a zero mortality condition in pediatric age group. I have lost a child. So can't say that it's a zero mortality condition. Second is that why the symptoms are less frequent. Possibly because children are able to mount a better response. Children have less comorbidities. Usually the diabetes and the hypertension and the obesity are not part of the children. However, compared to normal children with comorbidities are at higher risk. There is no doubt about that. Obese children are at higher risk of developing symptoms and also of the mortality. Similarly, those with diabetes, especially uncontrolled or hypertension, they are at higher risk. So that is not much of difference. It's probably because they do not have that much of comorbidities as we see in adults. That is why the mortality rate is less, and they are able to mount the immune response better.
And as said, symptoms of loose motions and vomiting, they are much common in children compared to adults. So one should be very alert when they present with. We think of acute gastroenteritis may turn out to be COVID. Second thing, apart from this, in our country, two hypotheses were put forth. One is the BCG vaccination in our country, whether it is beneficial against COVID also, a debatable topic. For that, the WHO has to come out with the notice. Although some countries they claim as to be it is beneficial, but still, as of now, we can't recommend BCG vaccination as a protective measure against COVID. One thing. And second thing, in vaccination, the term what is called as immunosenescence does take place. In children, the immune system is supposed to be very, very strong. And as the age advances, probably that immune system may not work as powerful as in children. So that may be the other reason for children being less susceptible or less manifesting with COVID symptoms. Mishra sir, any other comment?
Sir, can I ask one?
Sure, Dr. Min.
Sir, there was from some people were asking, is there a role of giving MMR injection for COVID prevention?
Again, a controversial thing. Again, it's a question of boosting the cell-mediated immunity with a virus which is very different from that of the COVID. So there is, at present, there is no studies to demonstrate that it works, nor the BCG vaccine that works. It's like, trying to boost the cell-mediated immunity. But then there is no evidence to say that it works.
Sir, that is a thing what I describe as a WhatsApp university, because there was a message from one of the medicos saying that after giving 2 doses of MMR vaccine 1 month apart, probably it imparts immunity and protection against COVID, but as Mr. said, no clear-cut evidence to suggest as a protective measure against COVID. So can't be recommended.
Thank you, sir.
So I think there has been a lot of discussion, sir, and it is time we should say good night to each other and to our audience also. If there is any one more question, Dr. Bhatia, is there anything in your mind? Please say it, or should we go? Dr. Bhatia?
Question to Dr. Sharma.
Yes.
Hello. Am I audible?
Yes, you are audible.
Sir, you are very much audible.
One question to Dr. Sharma.
Yes, sir.
A diabetic COVID patient under treatment of glycomet with mild symptoms, what is the alternative? Can he take insulin or any other alternative?
No, the patient, mild symptomatic patient, if he is well controlled on glycomet or
Yes.
metformin,
Yes,
there is no need to shift him to some other thing. But if he escapes the control of diabetes, he should be put on insulin therapy. That is a must. Because he cannot be relied upon, because whenever there is a disease process, there is an increased insulin resistance, there is a production of counter-regulatory hormones in the body, stress hormones in the body. They lead to escape of the control of the disease. So when he goes beyond the control, he should be put on insulin rather than relying on the metformin only. That is it.
So physicians in my hospital, physicians my hospital say that if you are putting these patients on steroids, then you must switch over to insulin. I don't know what is.
Yes, definitely. Yes, definitely. Because once you are putting them on insulin, you are putting them at the danger of hyperglycemia.
Right.
Because that will definitely unmask the disease. So you have to give them insulin therapy. So any patient who is with mild symptom, having no escape of the control, he can be put well on the metformin, can continue. But when he escapes the control, he should be put on insulin therapy. And if he is on steroid, definitely he'll be requiring insulin therapy.
Dr. Sharma,
Thank you, Dr. Sharma.
Thank you, sir.
Sharma, I just wanted to ask you, where you said that when the patient is not controlled by metformin, that means he goes out of control when metformin's maximum dose.
He is having just few mild symptoms. He is having sore throat, and he's not showing any other symptoms. But if he is seriously ill, he is in hospitalized condition, all hospitalized patients should be put on insulin therapy. That I have already told you.
That's true. That's true. That I agree with you. But if a patient is not controlled on metformin only, this you said just now, and he is not controlled by metformin only, that means up to when the maximum dose of metformin is being given, then why any other drug is not to be used along with metformin? Why the addition of some other sulfonylurea is not recommended? Why only insulin?
Because insulin is a more physiological drug, I think so. Because that is a very in any other disease there is a pyoderma, there is a wound healing that definitely promotes the healing of the disease. That is it. The patient,
Sir, I'll like to come on that. All the oral anti-diabetic drugs, they are essentially causing by increasing the sensitivity of insulin to most of them, at least. I do not know if there are recent drugs that have a different mechanism of action because I don't deal with diabetes on a day-to-day basis. They increase the insulin sensitivity. Now, if the one drug is not, acting by giving enough insulin sensitivity, the other drug is also not likely to benefit, whereas the effect of hyperglycemia on COVID is very, very dangerous. So therefore, everybody, all the physicians, they want to switch over to insulin immediately. Like in all stress conditions, when you are going for surgery, physicians normally shift these patients to insulin. So that is because of the stress condition.
Then the simple reason is that whenever the patient is serious, then all the physicians are advised to switch over to the safest mode of control of diabetes, and that is insulin.
Right.
Okay. Thank you, Dr. Sharma.
Thank you, sir.
Okay, Dr. Siroi sir, now your role is there. I think his internet is unstable. Because he is the moderator, we should wait him to come over and discuss the meeting. I should contact him.
He is there now.
Yeah.
Yes, Dr. Siroi, please.
Yes, sir. All the discussions are over now, and now.
That's good. Nice discussions and nice talks. I have learned many new things today. Thank you, Dr. Sharma, Dr. Rishi, Dr. Himanshu. Some people have already left. Dr. Satish, Dr. Sudhir, Dr. Tyagi, Dr. Jaggi. And thank you.
No, sir, I am here only.
Thank you, sir.
Thank you, sir.
I am here only, sir. Dr. Tyagi.
Okay, Dr. Tyagi, thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Thanks a lot.
Thank you.
I invite all the persons from Uttarakhand to be there in the annual conference also. It is on 6th December.
Yeah, we are also having, sir, we are also having our annual national conference of IMLEA, that is IMLEACon 2020. And this year it is going to be a digital conference on 4th, 5th and 6th December. And I invite you all to join it, because this will be very fruitful to all of us. So please get registered for that conference, and please do join, and please make it successful. Thank you.
Thank you.
And we should congratulate Dr. Anurag ji, as he is the organized secretary of that conference.
And he is my counterpart.
Congratulations, Dr. Anurag.
Congratulations, sir.
He is my counterpart.
Okay, sir.
That is the trick of the trade.
Okay,
that was the trick of the trade, Anurag ji. आप मेरी तारीफ करो, मैं आपकी तारीफ करूं.
No, it's not like that.
My special thanks to Dr. Ashok Shyam, who has done this on very short notice. He was thinking for the Sunday, but when I told him that it is day after tomorrow, then he sent the audience link in just no time. And thank you, Dr. Ashok. Thank you very much.
Welcome.
This OrthoTV has done a wonderful job throughout this COVID era.